Good morning. We're going to talk about the end of dual therapy with Renin Angiotensin Aldosterone system blockade. Okay, what is ES? Drugs that inhibit the conversion of angiotensin 1 to angiotensin 2, which is a vasoconstrictor, therefore causing increase of the artery pulse. Examples of these drugs are enalapril, captopril, ramipril, and fosinapril. This is a video of those drugs.
Angiotensin-converting enzyme inhibitors have been widely dedicated to research since the late 1950s. Initiation into the development of ACE inhibitors had begun from the discovery of an orally inactive peptide from pit viper venom. Today, in modern society, they are used extensively among patients suffering from primarily hypertension and congestive heart failure. The first inhibitor, captopril, had been introduced by the FDA in 1981 under the trade name Capoten, marking a revolutionary breakthrough in modern medicine. Captopril, being part of the first generation, laid the foundation, with eventual second and third generation agents making their way to the market with positive leaps and bounds. Upon the initial framework, we will take a look at its mechanism of action. The Renin Angiotensin Aldosterone system, also known as RAS, is where many biological reactions take place to form angiotensin II to increase blood pressure, along with the secretion of aldosterone and ADH. ACE inhibitors, being antagonists, are only the surface foundation for the specific actions within the body. Specifically, these inhibitors seize the conversion of angiotensin 1 to angiotensin 2 by antagonizing the ACE binding sites. This thereby causes a decrease in blood pressure in proportion to arterial resistance, cardiac output, and stroke volume. With further understanding into their mechanism of action within the body, we can effectively tackle the clinical use of these drugs. ACE inhibitors are effective treatments in dealing with not only hypertension, but a variety of cardiovascular diseases such as cardiac failure, acute myocardial infarction, and renal diseases including diabetes mellitus, chronic renal failure, and systemic sclerosis. We all know that the reduction in blood pressure is the main clinical effect of ACE inhibitors. However, there are significant other advantages in individuals as well. These medications work complementary by suppressing the progression of diabetic nephropathy and chronic kidney disease, thus in turn reducing cardiovascular risks. With such advanced treatment in today's generation, mortality rates of prone patients have depreciated over the years. Yet with the positive impacts, there are correlating adverse effects as with an expanse of drugs today. The most obvious listed is hypertension, a lowering in blood pressure. So let's examine the others. Hyperkalemia and excess retention of potassium ions in the plasma can occur due to the suppression of aldosterone levels in the body. Rash and taste disturbances are heavily prevalent in captopril in comparison to second and third generation ACE inhibitors. Also, there have been indications of prenatal malformations due to the administration by pregnant women within their first trimester. Research, however, is still going on into the matter. Overall, the superior advancements into these drugs have driven scientists to the dedication of providing more efficient drug designs. Probably the most major milestone as of yet is the discovery of two unique active sites on the angiotensin converting enzyme. The C domain, which is involved in the regulation of blood pressure, and the N site, having the possibility to open new therapeutic gateways. The N site also acts as an enzyme involved in metabolizing a homoregulatory hormone. The determination for the development of more third-generation drugs such as phosphinopril is the main driving force in today's pharmaceutical industry in utilizing these unique methods. As globalized healthcare continues to exceed every day, the aim of the future still lies within increasing the therapeutic effect while also minimizing the adverse effects.
Now, we're going to talk about ARFs. These drugs that antagonize at AT1 receptor, which are angiotensin receptor that cause vasoconstrictor, inhibiting angiotensin 2-free, which are vasodilators. In this case, we have losartan, candesartan, valsartan, and telmisartan as examples. Here's a video about ARFs.
Angiotensin receptor blockers. Angiotensin receptor antagonists, or blockers, ARBs, are also known as AT1 receptor antagonists, or SARTANs. These drugs are receptor antagonists that block type 1 angiotensin II, AT1 receptors. The angiotensin receptor antagonists modulate the renin-angiotensin-aldosterone system and are therefore widely used in the treatment of hypertension.
Now, we're going to talk about the effects. Combination of these two drugs can decrease level of blood pressure and microalbuminuria level, effects that are useful in the diabetic treatment. Nevertheless, there are more adverse effects than benefits. Failure to show cardiovascular renal protection, hyperkalemia, and renal failure. Now we have another video. Renin Angiotensin Aldosterone system.
Hi, in this video I'm going to look at the Renin Angiotensin Aldosterone system, also known as the RAAS. So this all starts with the liver. And the liver produces an pre-enzyme called angiotensinogen. And this gets converted into angiotensin 1. And this occurs through the action of renin, which is an enzyme released from the kidney. And the kidney releases this due to low fluid volume moving through the nephrons. Now, angiotensin 1 gets converted to angiotensin 2. And this happens by an enzyme called angiotensin converting enzyme. Now, these are floating around in the blood, these angiotensins. So it's when they pass through the lungs that they meet ACE, which lives in the lung. And that's when angiotensin 1 gets converted to angiotensin 2. Now, angiotensin 2 acts on the adrenal gland, and it causes the adrenal gland to release aldosterone. And that's a steroid hormone, which then acts on the collecting ducts of the nephron. This is within the kidney, and causes the nephron to retain water. So I'll put here H2O retention. Then if the body retains water, the blood pressure goes up. And in some people, this can be a bit of a problem. Now, I should also put in one other thing that's very important about angiotensin 2. Angiotensin 2 seems to be a factor in the inappropriate remodeling of the heart after a heart attack. And this can cause significant morbidity and mortality in heart attack patients. So let's have a look at some drugs which we can use to affect this pathway. The most common drugs are the ACE inhibitors. So these are the angiotensin converting enzyme inhibitors. So obviously these inhibit ACE. The next group of drugs are called statins, or angiotensin II receptor blockers, also known as ARBs, and they stop the effects of angiotensin II. And then a third set of drugs block the action of aldosterone. And the most important of these is spironolactone. It's also important to note that by blocking the action of angiotensin II, the ACE inhibitors and the statins can prevent the remodeling of the heart after a heart attack. So these drugs lead to a lower blood pressure and a better outcome after a heart attack. And that's an overview of the renin, angiotensin, aldosterone.
For more free tutorials and the PDF of this tutorial, visit www.handwrittentutorials.com.
Now, we've got the conclusion. Although the results indicate increasing efficacy of blood pressure control can increase the albuminuria, there were more adverse events than benefits. Thank you.